Okay, 7 p.m. Welcome everybody to the third installation of American Endovascular and Amputation Prevention webinar. Again, I know it's 7 p.m. because I'm sitting in my apartment in the city and I hear the cheers outside throughout Manhattan for all of the healthcare workers who have been involved in treating patients with COVID. So pretty much everyone on the call, that's you, they're cheering for you. So let me as well extend my gratitude to everybody on this call for what everyone's doing. I know everyone's doing their best and contributing as much as they can. The topic tonight is CLI imaging. The attendance keeps growing. It's good to see. You know, we put a lot of effort and energy into developing these to, sort of try to broaden the education very widely from those people who are involved in wound care through to those people who are involved in actually treating patients with revascularization and other methodology. So this is a really important topic, we think. I'm really thrilled to have with me Dr. Joseph Shams. He's another colleague of mine within American Endovascular and Amputation Prevention. He's actually located in Chinatown. And I know Joey for 35 years.
30.
Yeah, he and I were in the same residency together a year apart. So I'm not saying who's older. Actually, he's older.
I am older.
Anyways, with that being said, let's sort of jump right in. Two very important housekeeping issues. One is there'll be a poll. So really important that you answer the poll. We thought this would get people more engaged as we move forward in this and other webinars. So let's see how that works out. The other thing is please use the Q&A bar to answer any questions. We'll be monitoring that. And this should be interactive. So even though we have a 30-minute webinar, we've built in some time so we can address any questions which might arise. All right. So that being said, I'm going to start where I start each week, which is to talk about kind of the current state of the art, or what really should be the current state of the art regarding, optimized revascularization in patients with critical limb ischemia. Now, critical limb ischemia, as we learned from the prior webinars, we probably already know, is an epidemic disease, same population affecting COVID, diabetes, hypertension, obese individuals are susceptible to critical limb ischemia. That's why we're seeing such a rampant outbreak of COVID, because it's this population was very prevalent in the United States. And these are patients that we see with critical limb ischemia, and it's also not an elective thing. There are 300 to 500 major amputations a day due to critical limb ischemia. And it's really imperative for all of us on this call to not only practice, but to spread the word that we could do a better job. We could do a better job both in identifying patients earlier, making the appropriate referral, working collaboratively in team-like structures, and then sending patients when necessary and appropriate to places that do optimize revascularization. Because even though the American Diabetes Association says 50% of wounds are due to underlying diabetes, in reality, as we get more distal targets, pantarpedal loop, smaller blood vessels, in our experience, it's almost 80% of patients. So the old paradigm of treating only a little bit of disease certainly, has changed in American Endovascular and other places, and people who are dedicated to this, regardless of what specialty you might be, now have really advanced the field where we're perfusion directed, and we certainly can treat other people's failures, and that's an important thing. Don't think that just because one person didn't have success, it's impossible. We have new techniques, some stem cell strategies, deep venous arterialization, and other things. We're really very targeted to the wound vessel. We use a lot of really sophisticated techniques. In the end, we have some biological therapies. And this is sort of growing, and we're in an outpatient environment, but it's important to notice that, infrapopliteal interventions, which is critical limb ischemia, are really the fastest growing type of intervention because of the prevalence of the disease. And radiologists, I only mention this because, Dr. Shams and I, both radiologists, have been really, the forefront of, treating particularly critical limb ischemia. Well, we only treat 13% of PAD overall in the country. As a recent surveys, we're the fastest growing in terms of outpatient setting, in terms of treating patients with critical limb ischemia. And, all of us who do this, well, have this particular skill set. And it's a unique skill set. It's not your average individual just does a little bit of PAD. Critical limb ischemia is a unique skill set. So this is going to lead to our poll. I'm going to call this the index case. And we just pulled this together last night because we wanted to try the poll experiment. So this is an 85-year-old female, prior left lower extremity revascularization in February of last year. So about 14 months ago. And now with an 8-week non-healing painful right heel also. So she actually got into the system pretty quickly. She's already been identified, and now she's being surveyed. This is refractory to wound care and antibiotics. I'm not sure the picture does it justice, but it's probably a Wagner grade 1-2 wound, but painful. I'm not sure if you were to read this, you get down to tendon. Certainly underneath the blue area, more on the plantar surface, it seems to be a little bit more disruption of the subcutaneous tissues. Really, she doesn't have a lot of cardiovascular risk factors, but she is diabetic and has hypertension. Obviously, she's elderly, and we see a lot of elderly patients with PAD. That's part of the reason for the prevalence. She's on clopidogrel, metformin, but if you look at this, she's not on statin and not an adequate antiplatelet. So I'm not sure where that fell down after prior treatment, but she's a nursing home resident. I expect that in that transition, some of those necessary medications sort of got lost. And that's going to be a future topic, is medical therapy, is CLI. And you can see the picture, but she has a little bit of drainage from this, which makes me think it probes a little bit deeper, and very weak Doppelable DP, PT, and plantar perforator signals. That's the PP. That's the terminal portion of the plantar pedal loop, which can be heard between the base of the first and second metatarsals, which is where the dorsalis pedis communicates with the lateral plantar branch. So here's the poll. And once we get the poll, we'll sort of dive right in, but I'm going to really be very interested in getting Dr. Sham's sort of input on how he would evaluate and manage this patient as a, CLI expert within our program. So here are the choices. What would you do next? How you would evaluate them? Maybe just continue wound care, consider some hyperbaric oxygen, get some sort of imaging, duplex arterial ultrasound, CTA or MRA, maybe do some perfusion measurements with TCPO2 or skin perfusion pressures, refer for revascularization, or think in this patient with these risk factors and this is amount of disease, just send her for amputation as a definitive management. So this will take about 20 seconds or so for people to put up there. Host and panelists cannot vote, so I cannot vote. I already know my answer. But Joey, without sort of jumping into the answer, because I want to see what people say, and we're going to get into this. Why don't you sort of tell me just your consideration in general about who you image, right away, who you get perfusion on, and we're going to get into this, and who you just sort of give some time, maybe sort of temporize, and feel like there's not yet need for more immediate evaluation.
Okay, so thank you, John. Thank you very much. Just want to say that John, John's really excelled in this field, and I just want to give kudos to John for doing this series of lectures, which are really very informative for everybody. So, at my approach to these cases, basically, patients who have, patients can present with several different findings when they have chronic limb ischemia, right? So they can either present with, if they have chronic limb ischemia, they're presenting with ulcerations, frank gangrene. These are patients who obviously have significant multifocal disease on presentation. Once they're presenting with an ulceration, we know they're going to have something there, particularly most likely in the distal vessels. So my approach has always been to get as much information as possible. Obviously, we've got the history and physical examination, but the first thing that we'll do in our practice is perform ankle brachial indices and then a duplex ultrasound. Really, and I think, I don't want to steal John's thunder, and we're going to go through each modality separately, but we have a dedicated ultrasound technologist who's been, this is one that I'm working with now, has been with me for several years, very dedicated. We're constantly speaking with each other regarding the findings, so I can trust his findings. And once we get a basic ultrasound exam, then we'll go from there, either going straight to an angiogram, or if we need to, get further studies.
So that's great. So the survey results are in front of me, and you guys can't see them. So obviously, given the topic of the webinar, 56% of patients said they'd get imaging. Didn't say which one. We didn't structure it that way. 30% interesting said they would go for TCPO2. We'll see why that might be a good approach or not, what the merits and weaknesses are. Nobody sent for amputation right away. 9% directly for revascularization. And nobody said just continued wound care. So I think everyone sort of on this chat at least feels like some sort of additional evaluation is necessary. So let's jump into this, because obviously this is the crux of today. So we're talking about CLI imaging. So what does imaging show you? It's sort of a funny sort of word. I mean, imaging, to me, I think of kind of somebody's image, what they appear to be to others. But imaging in terms of vascular imaging is very broad and yet very specific. It's very specific, and that has very specific goals. It's very broad, and that there's multiple different ways to achieve those goals, and each modality has its strengths and weaknesses. But when I think of imaging, we were trying to get the hemodynamics. You can measure the pressures, as Dr. Shams referred to, the ankle brachial index or the toe brachial index, and I'm going to push back on him in a little bit in just a moment. Patency, clearly from our point of view, as people who fix blocked arteries, revascularize patients, we needed to understand the anatomy. We needed to understand the anatomy for a couple of reasons, other than just knowing the level of occlusive disease, and we'll see that too in a moment. Flow is a different concept altogether, and those are sort of waveforms, which we're going to review, and it gives you a sense beyond a stenotic or occluded segment. What is the flow like? Are the collaterals adequate? Is the narrowing hemodynamically relevant in terms of altering the flow parameters? And then finally, and probably the most important thing really in critical limb ischemia, is perfusion or oxygen delivery. Although while we do have some modalities, that's actually the least reliable and often hardest to measure. And there are just some pictures here on the bottom. This is a color flow arterial duplex. This is a CTA shaded surface display, and this is a MRI picture with some stenoses obviously marked by the arrows. And for each of these specific types of goals, there are specific tests. So for hemodynamics, that's ankle brachial indices, toe brachial indices, and pulse volume recordings. Pulse volume recordings are measured by taking a very low pressure cuff at 50 millimeters of mercury or so, and looking for pulsatile changes which are reflective of flow across the extremity. We don't recognize this, but our bodies are throbbing with each stroke of the cardiac cycle. And the amount that we have volumetric changes, therefore impedance changes in a cuff, is reflective of the volume of flow across that cross-sectional area. Patency is largely measured by the cross-sectional imaging, whether it be duplex, ultrasound, CT, or MRA. Again, I like the fact that Dr. Shams talked about relying on duplex, and so important that you have a relationship, as we'll see, with the person performing the duplex. Duplex can also sort of give you some flow patterns, and that's a unique advantage of it. And then perfusion, we're talking about TCPO2, skin perfusion pressure, and other modalities, which we'll only glimpse at a little bit here today. So here's my pushback at Dr. Shams, and Joey, you can comment on this. So I say that hemodynamics, ABI, TBI, even maybe PVRs, although they've been used for 1,000 years in clinical practice and clinical trials, the large part are not that utile in patients with critical limb ischemia. And this is published from my friend Mehdi Shishabor, who now is in Cleveland. And you see that across Rutherford class and across the type of runoff pattern, there's really no discernible difference in ankle brachial index. So it's not distinguishing for you the severity of disease or the anatomic pattern of disease. Even if you look at toe brachial indices, this is a different article by Dr. Shishabor. This is actually looking at impact deep data. Only 60% of patients who had critical limb ischemia actually met the toe pressure criteria. And if you sort of break it down here, you can see that 58% of them had an ankle brachial index less than 0.9, but 29, 30, 42% had a normal or supernormal ankle brachial index. So, that's not particularly reliable too. And I think we used to think that the great toe was spared calcification, which would prevented you from compressing the vessel. But it turns out that in these patients, everything's calcified. So that's not reliable. And about 30% of patients with critical limb ischemia will have normal ABIs. We just saw that. So, I would sort of push back. I don't think, we get these tests. It's a good baseline. But why don't you tell me, Joey, so you said you do these. What are you looking for?
So it's I actually agree with all your findings, and which are correct. I think there's two reasons why we do the ABIs. Number one, it's a good screening tool. A lot of these patients who present to us, well, obviously, if they have an ulcer, usually you can tell if it's an arterial ulcer, but sometimes patients may have neurogenic causes for ulcerations or pressure causes, and the ABI is just another component that may aid you in determining for sure that this patient has ulceration secondary to arterial insufficiency. Also, another important reason is just unfortunately a lot of the insurances will not approve intervention without an ABI. So that's just a technical reason that we have to get a lot of ABIs.
Right. And certainly, just to sort of clarify, in the patients with claudication, exercise-induced limb pain, ABI is a very reliable indicator, and also very important in patients with, asymptomatic or mildly symptomatic PAD. The severity of ABI directly correlates with the risk of coronary events over a course of 4 years. So it's actually an extremely useful screening test, more than many other screening tests, in determining cardiac risk and need for appropriate medication, aggressive medication, and cardiac evaluation. I'll also say that CTA and MRA, these are pretty fancy, but this actually is limited value in our experience as well. I mean, first of all, these are more challenging tests. You always have to check the kidney function, which might be a problem before they get either gadolinium and or iodine-containing contrast. They've got to generally be done at another facility. The quality of the studies and the reports is a little bit challenging sometimes because the people performing the studies are not as clinically tuned into what your goals might be. It's different maybe in an academic medical center, but certainly for those of us out in the community, these are not as reliable. But putting all that aside, the truth is that when you look at the critical limb ischemia population, this is an article going back about 12 years from Rueda, you can see that only about 4% of patients have either aortoiliac or aortoiliac and femoral disease, inflow disease. That's not really where the disease is. And the truth is that we can assess that just by a physical examination, a Doppler examination, a physical examination of the femoral pulse, assuming there's no surgical scars, to determine if that inflow might be a problem. And the great majority of disease, 75%, is in the below knee, with you see about 10% of patients who have femoral disease as well concomitantly. So for the most part, cross-sectional imaging is not that useful. And that sort of brings us to this point. So what do we really need to know? So certainly we need the anatomic pattern disease, an idea of the length of the occlusion. That's important for us to know if we can, how we're going to treat this, what tools we might need, and if we're going to need multiple access points. Certainly if it's stenosis or it's occlusion, the degree of calcification is really super important to us because that's a big determinant of the strategies we use for revascularization. Access sites. It used to be in the old days, there was a single access site. Everybody stood on the right side and would enter the right femoral artery. But as we become more sophisticated, we increasingly do these procedures with antegrade access, so we have better control of our tools. That means we need to know what the ipsilateral for the wound, common femoral artery, and proximal portion of the superficial femoral artery look like, if they're sufficiently patent to navigate tools and get purchase in the blood vessel to do interventions. And of course, we want to know if there's been other prior interventions so we can plan around that. And very importantly, as we'll see in the index case a little bit later, what anatomic variations there are. Because it turns out that below the knee, anatomic variations are more common than you might think. Only roughly 50 to 60% of patients have normal tibial anatomy. And finally, and this is really important as we expand our targets, knowing the status of the plantar pedial arch, and as much as we can, understanding the arterial wound supply is really important, because our goal, as you saw up front, is not just to revascularize target of opportunity, but to really revascularize wound artery. So what fulfills this best for us? Predominantly duplex ultrasound. I think Dr. Shams alluded to this earlier. And we all have in our facilities dedicated lab techs with whom we work, because an average lab tech, if you send them out somewhere, will also give you somewhat challenging data. They'll say tibial arteries are visualized or arteries are open, but they don't really give us the information we need, which is this list of criteria here. So it's very important that if you use an outside facility, you really discuss with them what you're looking for, these things. And of course, internally, we're constantly going back over with our techs what we're looking for, looking at the scans ourselves. And even then, I can tell you, because of calcification in particular, ultrasound is very challenging in this population. What does ultrasound look like? So Dr. Shams, why don't you walk us through these sort of normal and abnormal duplex patterns?
Sure. So the first image on top, we can see here is a triphasic pattern. We have the upstroke, downstroke, and then a small upstroke at the end. This is a normal pattern that you should see in normal vessels throughout the distal runoff vessels. Here we're starting to see some decrease in the amplitude of the waveform. It's not triphasic anymore. It's a little bit more lengthened, and this is a biphasic waveform, so we're just seeing two phases, upstroke, downstroke. So this is indicative that there may be some abnormality within the vessel below this. And then the monophasic signal, basically just one phase. And if you were listening to a Doppler, so you'd have the triphasic signal will be like a up, down, up. the biphasic, and then the monophase, again, you see how the amplitude is decreased, most decreased, and then it's lengthened out. It's almost like a concave, convex appearance here. A monophasic indicates that you have severe disease in general.
Right. And that's really critical limb ischemia. We call that tardus et parvis, slow and decreased amplitude. And you can also see, as you look at these signals get noisier. You get spectral broadening due to turbulent flow downstream from the stenosis. And obviously, no pulse is no pulse. And we have very specific criteria at the site of the stenosis, or velocity ratio at the site of stenosis to velocity proximal stenosis of 2 to 1. And this is the water hose effect, right? You have a water hose, you put your finger over the end, and you're going to get a jet. And the jet of that velocity of water out of the hose is directly proportional to the degree of narrowing up to a point. After a while, you get trickle flow. And you can see here, you can see very high velocity. In this case, 4.06, and the ratio is more than 2.1, 2 to 1. So obviously, duplex arterial imaging is primary, and it's got a lot of advantages. I mean, obviously, it's non-invasive, it's comprehensive, it's relatively fast, it's done in a facility, there's no contrast, it's easily repeatable and comparable to prior studies. But it's not perfect. Like we said, it's very much operator dependent. And the main limitation is calcification. It's definitely limited in patients who have wounds and or edema to some extent, where it can be very challenging. And inflow disease is a limitation because once you have diminished amplitude waveform, it's hard to discern additional levels of stenoses beyond that 1 point of diminished amplitude waveform. So after a while, if you have trickle flow, you know, it's going to be trickle flow throughout the entire limb, regardless of whether there might be additional areas of stenosis. So those are the major problems. It's not always accurate for these reasons. Calcification, hibernating arteries, which refer to arteries which appear to be occult or occluded, but actually are patent. They just have very, very little flow in them. Operator difficulty. Pedal arch disease is very challenging because of tarsal containment within the bony structures. And I think it's important to point out, and we're going to sort of see a case that a take-home lesson is that if you have a pulse or a Doppler signal, it doesn't mean you don't have CLI. If a patient comes in, you can hear a very strong, DP pulse, but the wound is in the heel. That obviously that doesn't include critical limb ischemia because of the presence of potentially compartmental ischemia or regional ischemia in the foot, which again is very important. So I say that because, I think we would all agree on this call that certainly good clinical acumen, experience, exposure to these sort of patients on a regular basis is important. And early angiography is a very reasonable approach if there's some sort of discordance in what you think is going on and what the imaging might show, or if the imaging is inadequate. We're going to come back to that in the index case. Let's take a little bit and talk about perfusion. We're sort of tracking well here time-wise. So perfusion, like we said, is, if you like, maybe the most important measurement. If we had a broadly reliable way of measuring oxygen delivery to the tissues, that would be the most important thing to determine if, in fact, there's enough blood flow for healing. So there are a couple of tools that that we can use. There you go. So trying to answer a question at the same time, sorry. But we mostly use transcutaneous oxygen tension measurements. And you can see that's on the left. These are just some sensors that are placed on. They stay on for each position for about 10 minutes. You do it with the leg in a neutral position, elevated and dependent, to see if this changes the gravity-assisted flow. Some people will do oxygen supplementation through a nasal cannula as well to see if that improves perfusion, kind of as a measure as whether hyperbaric oxygen or some of those modalities might work. Skin perfusion pressure is a different modality. That's actually a laser oximetry. And then this fluorescence angiography, which is a very pretty picture down below. That's a Novadac system, spyglass system. And not everyone has it, but has also been a relatively validated system. How do we interpret these perfusion, measurements? Oh, this is something down the line, by the way. This is, an implantable thing, which will be able to allow you to measure over time perfusion, sort of a glimpse ahead. So how do we evaluate these? So certainly for TCPO2, which is our predominant modality, I think that if you have more than 50 to 70, you're probably okay. Above 70 is normal. More than 50 is generally adequate perfusion for healing in the absence of edema, bony surfaces, and/or wounds, which might interfere with measurement. 30 to 50 is that gray zone. And if you're less than 30, that's critical limb ischemia and warrants revascularization. And this, as I alluded to, shows you some of the areas in which TCPO2 may not provide the most accurate measurement. So bear this in mind, particularly if a patient with edema, a lot of inflammation. If you're measuring over bony prominence, or you have to measure through a wound, or if the patient has collagen vascular disease, you may be limited. And at the end of the day, there are ways when we actually do our procedures to measure perfusion, or at least to measure distribution of blood flow. Maybe not the best measure of oxygen delivery, but obviously where blood flow goes, oxygen will go. And this is methylene blue. In Asia, they use indigo carmine. It's injected into a specific vessel to see the, the staining, and we're looking for circumferential staining around the wound. And you can see from this angiogram, this is an angiogram, that the correlate of this, which has been shown to highly relate to wound healing, is that when we're done, we see a wound blush in the area where we've revascularized. And Dr. Shams, did you say that's one of your goals is to try to achieve that wound blush?
Absolutely, absolutely. I think once we see the blush, I mean, that convinces us that we have the vessel that we need to treat, and we need to get flow going into so that we can heal this wound. So I think it's really important for us. Right. I think you've coined the term angiographisome.
Angiographosome.
Graphosome, correct. Yes.
That's the wound vessel. That's what we want to open up. So, so pre-procedure, we use this if there's a challenging revascularization, particularly a small wound. Before we move forward with some potentially morbid procedure, certainly in complex pattern disease and patients with substantial comorbidities. But really, very often we use it post-procedure to determine if we got it. If there's residual disease, if it might be a different angiographosome than we anticipated, if there's compartmental ischemia, and if in patients we can't open direct flow, if there may be an adequate collateral bed to allow wound healing, or before we move forward to other modalities, such as deep venous arterialization or stem cells. Certainly it's very important in cases where we have some anatomic uncertainty about the adequacy of blood flow to the wound, and helping us decide if we have enough oxygen delivery for wound healing. Recognizing that it's normal in the Olive Registry, 40% of patients need repeat intervention. That's anticipated, and our experience is closer to 25. So in summary, our imaging algorithm is that our first study is usually duplex ultrasound. I think we've really kind of articulated the reasons why. If we suspect inflow disease by our examination, predominantly, or maybe the clinical presentation with a buttock and thigh claudication antecedent to the critical limb ischemia, then cross-sectional imaging has a role. But remember, that's only going to be 5% of patients. If there's a lot of calcification, which obscures the evaluation, again, you can consider cross-sectional imaging. Although I think, honestly, we tend to go early to angiography, and that's sort of what we're thinking, in patients with severe critical limb ischemia. And it's amazing how often you'll find disease, and appropriate disease, amenable to revascularization that allow wound healing. In those cases, we still use duplex, like we said, to assess those access points so we can get into the artery and treat the patient. So, Joey, let me ask you now, as I didn't ask you, so what would you have done with this sort of index case? Remember, this is an 85-year-old woman with this wound. Everyone said get a duplex, so here's our duplex. What do you think?
Okay. Looks like we can see here on the on this initial duplex, she has a triphasic signal in the popliteal artery. So we assume that she's not going to have inflow disease. So we assume that she's clear up to the popliteal artery, and it looks like we have very, very slow flow. It must be occlusion in the anterior tibial artery. I'm not seeing the lower part of this, but there may be a slight amount of flow in that anterior tibial artery. You're covering me on the. Hold on a second. Okay, so now I can see. The posterior tibial artery is occluded. The perineal artery is difficult, and frequently, unfortunately, especially even with us, the perineal artery is an area which is difficult to image. Sometimes we get reports saying that the perineal artery is occluded, but then we do an angiogram and the perineal artery is open. So just from looking at this Doppler report, I'd be very concerned that this patient has occlusion of the perineal, the posterior tibial artery. Okay, so here we see the angiogram, and then
jumping ahead.
yeah,
sorry.
Okay, and then very slow flow in the anterior tibial artery. So,
here was the interpretation, by the way, of the duplex. They thought they saw some flow in the AT, distally reconstituting, perineal PT occluded. Perineal PT occluded. So yes. I think this is important because here's the angio.
Correct. So what we see on the angiogram that the anterior tibia looks like it's open proximally, but then it occludes in the proximal calf. The perineal artery is open throughout its course without significant disease. and it does reconstitute the anterior tibial and dorsalis pedis artery here. I would, obviously with the ulceration, it appears to be in the region of the posterior tibial artery. We're not seeing a blush here in the region of the ulceration. So I would be concerned that we need to recanalize the posterior tibial artery. And now we're seeing wire going down and a catheter going down the posterior tibial artery. And we see a branch directly into the area of the ulceration with some blush here. So clearly, I think now that we have recanalization of the posterior tibial artery here, this is probably performed using either atherectomy, angioplasty, whatever you want to use. And then we do have flow into the area of the ulceration. So I'd be confident that this would be enough to heal this wound. This is a nice result.
All right, and this patient did great. So it shows you some of the limitations of duplex. Remember, we interpreted the perineals are closed.
Correct.
It didn't show the anatomic variation of perineal continuation into the dorsalis pedis,
Right.
but it gave us the information we needed to move forward to angiography, identify the culprit lesion, which is posterior tibial artery occlusion, restore flow directly to the wound vessel, the angiographosome, and see this blush at the completion of the procedure. So we're sort of done here. I mean, I think hopefully, we sort of made the point. I think together we can make a difference. This is an epidemic disease. It continues to increase in prevalence. And working collectively, everyone on this call, we have the ability to make a difference. And even with complex wounds, with diligent care, follow-up, wound care, repeat revascularization when needed, and of course, appropriate cardiovascular medications, we can save life and limb. So let me thank you, Dr. Shams. You want to say something?
Yeah, I just wanted to make two quick comments. Number one is, again, these are reiterating points that you already made. Number one is just because a patient has palpable pulses does not mean that they do not have a vascular wound. Frequently, clinicians, podiatrists will tell me that, oh, well, we think we felt pulses and therefore we didn't think it was a vascular etiology. I can't tell you how many times, patients have come to us, particularly severe diabetics, particularly patients with Charcot feet, who have, beautiful vessels up to the ankle, and then have severe disease in the plantar arch and plantar vessels. And with revascularization, we can really heal these wounds. That's the first point. The second point is, I think that really, performing interventions within the distal vessels has really revolutionized this field. When I started in this field 20 years ago, we basically were treating proximal disease and maybe SFA disease. But now that we're able to treat tibial vessels, plantar pedal vessels, it really is making a big difference in healing ulcerations. And the proof's in the pudding. I think, once you see one of these cases, it really opens up your eyes to see how much we can do to help these patients.
Fabulous. And just to answer your question, how often do we go up and over for the contralateral groin versus antegrade? We go antegrade whenever possible. And at this point, almost 40% of our patients, if not more, will get a pedal access as well. This really keeps our options open for intraluminal recanalization, through and through access, make sure that we reconstitute the vessel at the point where collaterals are naturally reconstituting it and don't extend dissections. And really, that's what I say, we need that pre-intervention information to make sure that the common femoral artery and proximal portion of the SFA are open and have a sense of what the tibial targets are for puncture, although we may see that from angiography. So once again, thank you so much, everybody attending. Thank you, Dr. Shams, for your participation. Thank you, Dr. Herman, my partner, for answering these questions throughout this. That's been fabulous. We ran a little bit over with the poll, a couple of minutes, but hopefully this has been really valuable. As you see, we're passionate about this, and we want you to be passionate about this too. And we look forward to seeing you again next week.